Assalamu alaikum warahmatullahi wabarakatuh. Welcome to one of our quick sessions in which we summarize together the green top guidelines. Our guideline today is number 47. It's talking about premenstrual syndrome or PMS. And I consider this guideline one of the most challenging ones because it contains many informations. And of course, it's one of the latest. This video for sure is coming to you by eMRCOG online sessions. And inshallah, today we will try to make it as simple as possible and we will make every point memorized for all of us. To diagnose and treat PMS, you should know what is PMS. You should understand the physiology of PMS as much as you can. And when you choose the line of treatment, you have to choose it accordingly to your patient daily active life, according to her wish, of course, according to her desire of pregnancy, according to many things. That's what makes PMS tricky in diagnosis and tricky in treatment, but still very simple to diagnose and treat, inshallah. So, what is PMS? PMS is a diagnosis of timing rather than the type of symptoms. What I have to know as a doctor is when the symptoms appear. If the symptoms appear in the luteal phase of menstruation, this means it is usually PMS. But what if it appears in another part of the menstrual cycle? So it will be either a variant type of PMS or it is not a PMS. So the symptom cause significant impairment to the individual during the luteal phase of menstrual cycle, and those symptoms have to go on for two subsequent cycles. Retrospective recalls of symptoms are unreliable. I should not diagnose PMS according to symptoms that happened to my patient 3 months ago and 2 weeks ago. No, I suffered from nostalgia for the last two periods, but before I had acne and depression, and before I remember I have bloating and other things. This is unreliable. You should have two subsequent cycle symptoms. The symptoms should impair your patient daily life, and of course, the timing is crucial for diagnosing PMS. It has to be in the luteal phase, and usually the symptoms subside by the menstruation, which is typical PMS. There are other variants of PMS, and this is why there is what's called by daily record of severity of problems. This cute table, as you can see, will help you diagnose PMS. Your patient will take it home, she will fill it, and comes to you, and you need for at least 2 full months of ratings. She will put down, and you will decide afterwards if she's suffering from PMS or not, and if it's mild, minimal, moderate, severe, or extreme. Who should treat PMS? You may think that you, as a gynecologist, are the first one who saw this patient, while in reality, the GP will see her before you and will offer her the first line of treatment too. He will offer her the COP, he will offer her the vitamin B6, even SSRIs can be prescribed by GPs. And then, if this line of treatment fails, he will refer it to the gynecologist, which of course he can use the help of psychology and establish the plan of treatment with the GP and the psychologist together as MTV. Does my treatment hormonal or non-hormonal? Actually, this is not the line of your treatment. This is not the first line of your treatment. The first line of your treatment is cognitive behavior therapy. This is routinely must be offered for every patient with PMS. Yeah, medical treatment is one of the first lines of treatment, but you have always to offer your patient cognitive behavioral therapy, no matter what stage she is in now, no matter what is the line of treatment she's taking now. You have to ask her, did you ever hear about cognitive behavioral therapy? Are you in one of the support groups? Are you talking to a therapist? If she's not, please offer her cognitive behavioral therapy. Second line is medical, third is surgical, and others are like complementary treatments, which mostly depend on herbs like hibiscus, primrose, saffron, and others. And your aim in choosing any hormonal treatment will always depend on what is best for your patient, what is best for her desire for pregnancy. You have to tell her everything about the side effects of this treatment, the indications and contraindications too. This is what is tricky about PMS, that every line of treatment carries huge risk for many complications. So you have to inform your patient, and she has to take the responsibility and the choice. She has to make the choice herself according to the information you are giving her. As for example, we will now imagine a patient in front of us and we are offering her the lines of treatment. We will offer her COC. She will say what kind. I will tell her drosperinone containing COC is the best. How should I take it? You have to take it continuously rather than cyclically. It is um, considered or suggested to be more effective. Okay, can I use something called estradiol patch or percutaneous estradiol? Because I heard about it from my friend and I don't like pills at all. Yeah, ma'am, you can use it, of course, but then we have to take alternative barrier or IUD device for contraception, and we have to give you something called microionized progesterone because estradiol alone will cause something called endometrial hyperplasia, and estradiol alone can introduce you to PMS like symptoms. And to avoid this, we will add micronized progesterone, continuous, of course, or cycled as you like, or long-term progesterone with the Lenovo, of course, Lenovo IUD, LNG IOS, and this will secrete progesterone inside your uterus for a very small amount every month, and this should prevent the side effects of estradiol, of course. Okay, she will say, okay, and how long I will be taking estradiol? Can I take it like forever? Should I take it forever? You will tell her, okay, actually, we do not know what is the effect of long-term effect of estradiol on your breast or your uterus. There is very uncertainty about this, so we should decide this together and take into your account the risks and the benefits, and we will decide if you can take the side effects or you cannot bear them. If you, of course, suffer from side effects, we will stop it and look for another line of treatment. If you fear of side effects, we can choose another one. But I'm honest with you saying that we do not know the effect of long-term estradiol on your body, especially breast and uterus. She will say, okay, I don't like this line of treatment, I need another. Can I take something called danazol? I have heard about it, and they said it has a very good effect on PMS, especially breast symptoms. You'll tell her, yeah, it is, but it has a potential reversible virilizing effect. And this is something you have to take care of, because the potential of irreversible virilizing effect may bother you a lot more than PMS. Growing hair in your face and private areas, you will not like it. Changing in your voice, you will not like it. So make your mind, and please, if you are going to get pregnant, tell me because I need you to stop it before becoming pregnant, or it will affect your female fetus. Or we could use, of course, any kind of contraception that you can bear or okay with. Next line is GnRH, the most famous one. Gonadotropin releasing hormone is not recommended routinely for whatever. It's not recommended routinely, and I know some hospitals that give GnRH as first line of treatment, and this is a mistake. This is a big mistake. GnRH analogs should be offered only to aid diagnosis or to treat severe cases, or before going to surgical operation for PMS. Those are the three indications for GnRH. And you have to think about bone mineral density. Okay, your patients say, doctor, I don't wanna see any kind of blood. I hate menstruation. I want something to suppress the menses once and for all. I don't like COCs, I don't like IUDs, I don't like danazol, I don't like estradiols, I don't like any of those. I want to take something like one shot that I don't have to take daily, and it will resolve all my problems. Okay, GnR NRH is very highly effective in treating severe PMS, of course, but we have to think about the bone mineral density, and especially if it's for more than 6 months, of course, we need add back hormone therapy. And tell her that she will suffer from postmenopausal symptoms. Postmenopausal symptoms like hot flushes. I think mommy won't like it. It is menopausal like symptoms, and your ovary will be suppressed. There will be no ovulation, okay, and there is no menses, but it will affect your bone density, and you will have to do DEXA scan every year, and the treatment should be stopped if DEXA scan uh, show us bone density declination. And of course, we need add back hormonal therapy after 6 months of using. And of course, we can use it as a diagnostic tool if PMS is unclear for 2 months, prospective daily record of severity of problems, which we saw before. GnRH analogs can be used to establish and or support the diagnosis of PMS. How? It is so obvious if the ovarian if the ovary is suppressed and there is no menses, the patient should come to you saying that there is very much resolving of my symptoms. I'm much more better. If not, it is not PMS. If symptoms still there, of course, but if the symptoms relieved, I'm sorry, it is PMS for sure. Should we use POP alone, or should we use the LNG intrauterine device alone? Should we use progesterone alone? No. Progesterone is not supported to be used alone. there is good evidence to suggest that treating PMS with progesterone or progestogens is not appropriate. Take care because this is one of the new guidelines notes. And now we are going to talk about non-hormonal therapy. Non-hormonal therapy, of course, will be mainly selective serotonin reuptake inhibitor or SSRI. How they are used? They should be considered one of the first line pharmaceutical management options in severe PMS. Take care, it is not the first line of management in mild or moderate PMS. They should be used only in severe cases as a first line, not GnRH, as we said. And we will, um, I'm sorry, and we will revise the order of our lines of treatment in upcoming slides, inshallah. What is the dose of SSRI? Should I take it in luteal phase only or continuously? It can be taken luteal or continuous, either are fine. And the main problem of SSRI is the discontinuation. You have to discontinue SSRI gradually to avoid withdrawal symptoms, especially if it is given on continuous basis, of course. What is the side effects that I should know about SSRIs? Nausea, insomnia, somnolence, the irritable sleep. I cannot sleep. Fatigue, reduction in libido, which is very important. Is there evidence for improved efficacy with other SSRI regions? When using SSRI to treat PMS, the efficacy may be improved and adverse effects minimized by the use of luteal phase regimens. So, if your patient asks you, should I take it in luteal phase only or continuous? And you say it's best for you to take it in luteal phase. Both are good, both are recommended, but if you need my advice, I will advise you to take it in luteal phase only. Does it affect my pregnancy? Yeah, it should be discontinued prior to or during pregnancy. And if you have any desire to get pregnant, you should counsel at every opportunity. You should ask your patient at every opportunity about her desire of pregnancy because she may not keep it in her mind, of course. So, to brief, SSRI problem is method of discontinuation, the effect on pregnancy, and how it will be taken. And we said it is recommended to be taken in luteal phase much more than continuously. I should tell my patient how to stop it gradually, of course, and I should tell her that there is a very high risk of congenital malformations in case of pregnancy while taking SSRI. What about diuretics, which is a very famous line of treatment too for PMS in some countries? You can use spironolactone in PMS patients to treat physical symptoms, but take care. Spironolactone is a potassium depleting diuretic, and this should be kept in your mind. If you are dealing with any drug, you have to keep in your mind the side effects of this drug, or you will make your patient suffer from another condition that you have no idea about it. And finally, you will discover that what she's suffering is the side effects of the treatment. And this is what's tricky about PMS, as I said. Other complementary treatments, I want you to just review it. exercise, reflexology, um, ginkgo, of course, the saffron, evening primrose, vitamin D, acupuncture, lemon balm, curcumin, wheat germ. Each of those have some benefit, and the type of studies are mentioned here. But as I said, those are complementary treatments or therapies. Let's revise together. And this is what's tricky about PMS. Uh, what's tricky about PMS too is to memorize everything at the same time and how to be organized in the line of treatment, how to offer your patient the line of treatment. First, you have to decide what is the kind of PMS your patient is. Is she a typical PMS? Is she what is called by core premenstrual disorder? Or she's just having what's called by premenstrual exacerbation? Or she has a premenstrual disorder with absent menstruation? Or it takes progesterone, so this progesterone induce a premenstrual disorder symptoms, or she is just having underlying psychological disorder, not premenstrual disorder. If you can see here, you will see graphs. These graphs are the timing of symptoms. That's why I told you in the very first slide that the timing of symptom is crucial for diagnosing. If the symptoms is exacerbated in luteal phase, then this is a typical core premenstrual disorder which has symptom free week, which is the menstruation, and if it is a symptom cyclical and relieved by menstruation and have symptom free week, but it does not influence on quality of life, this is a physiological premenstrual disorder or mild one. If we have to go through all the graphs, it is so easy when you just keep in mind that the timing is crucial and absence or presence of menstruation and its effect on symptoms is crucial too, because we have some patients with variant types of PMS that has no menstruation at all, but their symptoms are cyclical and they have symptom free week even without menstruation. Those are treated as core premenstrual disorder or as the typical premenstrual disorder. What if my patient is taking progesterone, any kind of progesterone contraceptive pills or injections, and she has symptom like premenstrual syndrome? I will give her alternative progesterone treatment. This patient mainly will be suffering from cyclical symptoms relieved by menstruation, symptoms free week, affects quality of life. But the key word here is that she is taking already progesterone. This woman is already taking progesterone treatment for whatsoever. So I have to make alternative progesterone treatment for her. Of course, if the symptoms are not cyclical and there is no free week of symptoms, and it always influences her quality of life, for sure this patient is psychological disorder, which is the last one on the right. You will see that her symptoms are mostly like plateau symptoms. It's always high, it's always high all over the time. Menses, no menses, before menses, during menses, after menses, and it influenced her life greatly. My patient is mostly psychological patient. Next, you will have to know how to classify your patient, and we said so. Give her the treatment options, of course, and then if the treatment fails or the line of treatment fails, you have to refer her. Let's see the algorithm. I'm sorry for this technical error. Let's see the algorithm once and for all. Just remember to understand the etiology of PMS. Diagnose your patient according to the definition of PMS. Classify her if she is core PMS patient or there is premenstrual exacerbation. If it is a premenstrual disorder with absent menstruation, and we will treat this patient like a core premenstrual disorder. If my patient is taking progesterone, so she have what's called by progesterone induced premenstrual disorder, or my patient is mostly psychological patient, she's not suffering from premenstrual disorder, and she will just need a psychiatric referral. This is what is PMS like, and we are in the end of December 2019, so I wish all of you Happy New Year. Farewell 2019. It was a heavy year for me, and thank you everyone for watching. Please give our Facebook page a visit. Of course, if you like the video, and if you don't like it's okay. And give our YouTube channel a visit also, and please subscribe if you want to see more videos about it. We are always open and welcome any kind of suggestion or correction or whatever you want. See you soon, inshallah. And if you have any question about PMS, write it in the comments. Bye bye.